everyone tonight. My name is Cindy Wu. I'm the lead Next Generation editor for the Aesthetic Surgery Journal. Welcome to our 8th live journal club, which is held the first Tuesday of every month at 8 p.m. I want to thank the ASJ staff, Phaedra and Kylie, who are on the call tonight, who work very hard behind the scenes to organize this event every month. I'd like to take this opportunity to introduce the author of this article, Dr. Jens Berli, who is an assistant professor of plastic surgery at OHSU. He completed general surgery training in Zurich, Switzerland, plastic surgery training at Johns Hopkins, and specializes in gender-affirming surgery at OHSU. And our moderator tonight is Dr. Loren Schechter, who also specializes in gender-affirming surgery in Chicago, Illinois. He completed his general and plastic surgery residency at Pritzker School of Medicine and a fellowship in reconstructive microsurgery at the University of Chicago. He is on the board of directors for WPATH and president-elect of the American Society of Gender Surgeons. Dr. Berli has prepared an overview of the article, and then we can open up to questions to the audience. For those of you who are joining us via video, please type your questions into the chat box at the center bottom of the screen, and you can designate it to either go to everybody, Phaedra, or myself. For those of you who are joining by audio only, please email your questions to Phaedra, Phaedra @surgery.org. And for people who can't join us tonight, this will be recorded and available on the ASJ website. So with that, please, let's have our slide.
Hello, can everyone hear me? Good evening, my name is Jens Berli. I'm out in Portland, Oregon, and I want to thank the Aesthetic Surgery Journal for having me on here today and be able to present the work that we've been doing and hopefully have a good discussion with everyone. So the title of my talk and the paper is What is Non-Binary and What Do I Need to Know? A Primer for Surgeons Providing Chest Surgery with Transgender Patients. And one of the impetus for this study really was when I looked at, articles that have been published in this, it's not a new field, but, it's getting more traction. They're very often focused on F2N, N2F, meaning trans female and trans masculine, so just on the binary end. But the reality of people that are providing care for those patients is that we do see a lot of patients that are non-binary. So it's very important that we're, also take this patient population into account. Next slide. For, those of you who are not too familiar with some of the definitions, just to get everyone on the same page, keeping it basic though. So sex, is really the phenotype, the way, someone's genitalia are, secondary sex characteristics that develop. And then gender identity is separate from that. So this is more the fundamental kind of true feeling of the sense of self, of how someone identifies. And, as the title of the talk insinuates, that's not always on the binary end of the gender spectrum. And then gender incongruence is really when those two things collide. So when someone's gender identity is not aligned with the phenotype. Now, there's many folks out there for them that may not be a cause of distress, but there are a lot of people where that causes emotional as well as physical distress, which is called gender dysphoria, which is what we're, treating. Next slide. Just to put that into perspective, just wait for the next slide to load. So, how many people are, does that affect? The estimates by the Williams Institute, is around 3 out of 500 individuals in the United States. And to put that a bit into perspective, in kind of real numbers, next slide. So in my region, you can see Oregon has around 27,000 folks that are trans-identified. And the estimate is that around 70% will have some form of medical or surgical intervention. Next slide. So modalities that can ease gender dysphoria. So it's not by no means just surgery. So, the simplest thing can just be aligning your gender expression. So the way you carry your clothes, your hair, makeup, things like that. Medical therapy such as hormones, and then mental health or psychotherapy can be really helpful to kind of adjust to the stressors that come with it. And then another thing that's really important and often kind of not talked about a lot is societal acceptance. So it really depends where in the country you're having your practice. Patients may have less or more distress when they, when they're outside, in the societal structures. And then there's non-surgical modalities. So, hair removal, speech therapy, things like that. And then lastly, surgery. Next slide. So this is a patient of mine that I think really illustrates very well the combination of hormones and chest masculinization. You can see him on the first day of getting his first testosterone shot on the far left, and then on the right side after, a few years, later after having undergone chest masculinization and the full effects of the hormone. And I want to point out just, kind of the body language, the body posture, the way, the smile evolves and things like that. Next slide. So this is by no means a new phenomenon, because it's so, much in popular media at the moment, and, a thing that everyone talks about. It could be amiss to think that this is, just a cultural kind of phenomenon. This has been, happening in many cultures and many times in human history. So the two-spirited culture in the Native American population, Ottoman Empire, in the Hawaiian culture. And then on the right side, you can see, quote unquote, a more, modern non-binary person. And you can also see on that slide the pronouns. So those patients, not always, but very frequently go by they, them, and theirs. So it's custom to just be, ask the patient what kind of pronouns they're using, and making sure that your staff and everyone at your office is also attuned with that and uses the right pronouns. Next slide. So the study question really was, at least in the population that I've been seeing together with my partner, Dr. Hansen here at OHSU, like how many of our patients that come for chest surgery are non-binary identified? And then what surgeries are they looking for? But then really using these kind of more simple kind of questions to kind of launch a discussion around this population, because really there's not much out there in the literature that can help other surgeons kind of, guide through the questions that may arise. Next slide. So this was a retrospective chart analysis of all patients that came for chest affirming surgeries, both chest feminization and masculinization between 2012 and 17. They self-identified on the intake sheet. So we have an intake sheet, we ask pronouns, we ask their gender identity, and then we sent out a quality of life, a non-validated questionnaire after surgery. So results, in the time period, we treated 458 patients. Of those, 13 were identified as non-binary. 58 patients were included in the study. You can see the age range and BMI range on that slide. So age 18 to 48, and then a BMI of 28, mean BMI. Interestingly, only 64% of patients were on cross-sex hormones, and we can talk a little bit more about that later. But that is, a relatively low rate compared to the more non-binary identified transgender population that we see. And then all patients were sex assigned female at birth, and 7% had previous chest masculinization or some type of chest surgery. What we see relatively frequently is patients presenting to other surgeons, and they may not be comfortable with doing a mastectomy, and they'll offer breast reduction, which obviously doesn't treat what they're really there for, which is a masculinization of the chest. If you look at the results of what types of techniques, so the double incision free nipple graft is the most frequently asked for procedure. The DI on this slide refers to a double incision, so a mastectomy where the incision is kind of placed in the pectoral shadow, but without nipple grafts. So 19% of patients opted to not have nipple grafts, which was much higher than in our more binary identified trans population. And then there were patients that had other surgeries such as periareolar. On the next slide, you can see some examples. So here, double incision with free nipple graft. Next slide. And here, a double incision without nipple grafts. If patients do regret later that they don't have nipple grafts, they could always tattoo them on or have reconstruction. So from, this is my personal bias. If I have an atypical request with lower risk than that, then I'm willing to do so if the reasons align with the patient's desires. And then next slide, just an example of periareolar incision type. Next slide. In terms of the quality of life outcomes, granted this is a non-validated questionnaire, but we had a relatively good response rate of 56% of patients that filled it out. It was a simple kind of scale of 1 to 5, with 5 being strongly agree. And you can see from the numbers that an overwhelming majority of patients said that it improved their quality of life, and most notably, close to close to 100% said that it improved their comfort in a t-shirt. And this may be important for people not so familiar with this population, and because a lot of patients are trying to hide their breasts by means of binding and wearing very loose clothing. Next slide. There are some, limitations with this study for sure. It's a non-validated questionnaire, and then also the time points where it was sent out to patients after surgery had a very wide standard deviation. And it's only post-operative data. We don't have the preoperative data that correlates with it. And then the patients are self-identified on the intake sheet, so it's conceivable that folks came in and just said, I'm trans male, because they're used to getting easier access to care, not presenting as non-binary. So the true number may actually be higher than what we saw in this study. In national data, it's around 20%. So with that, I would open this up for discussion.
So thank you, Jens. I appreciate that. And it was a wonderful article and very helpful, I think, in raising awareness to what we've traditionally called a non-binary population. I think for people who are performing gender-affirming surgeries or considering performing these surgeries, it's important to recognize that the population of individuals is heterogeneous, and that individuals we reference as non-binary or perhaps gender diverse or gender expansive do represent a large minority of people, probably most individuals undergoing chest masculinizing surgery. I just have a couple questions for discussion for Dr. Berli. Jens, do you think the age of patients who self-identify or identify as non-binary is younger than kind of traditional trans men?
Yeah, sorry, I just unmuted myself. So, I think from the results also in this study, you can see that the mean age range, is between 18 and 43. We didn't include, any, patients that are, younger than 18. So, compared to our overall population that we're treating, that age range, I agree with you that patients present a little bit younger. I do think that younger individuals are more comfortable, expressing that gender identity. I think in part, society has, opened itself, more up to the idea of gender and gender non-conforming individuals. And so, people just own their identity a bit, are more comfortable kind of expressing that. Now, I don't know if that's if we're gonna see some, more older patients come in and, kind of have that same desire. So far, we have not seen that. The other thing that is a little bit of a, kind of a geographical bias, we do see in Oregon quite a bit of patients that are moving, from other states to Oregon. And so when you look at the Oregon Health Plan, about 20% of patients, that receive care through the Oregon Health Plan have previously not lived in Oregon. And I would think that a younger patient population is probably more geographically mobile than someone that is like in their 50s or 60s, and probably is less likely to move to a state or a city where there is a gender affirming program. So there's many factors that may explain that.
Thanks, Jens, and we would of course like to open this up to discussions from the attendees, and while people are perhaps gathering their thoughts, I'll ask maybe just a couple other questions. You raised an important point about incision choice, and you mentioned everything from wise patterns, etc. Our experience, my experience, is I think similar and consistent with yours. Have you found that in individuals who have perhaps had a wise pattern incision, that their dysphoria has intensified or heightened following surgery? And my point being that designing the operation, the appropriate operation for the patient is quite important, and it's important to recognize goals and expectations, and that kind of if you're only comfortable performing a WISE pattern and thinking that a breast reduction may be an appropriate operation, what are your thoughts or thoughts related to concerns on worsening one's gender dysphoria, specifically because those are often very traditional feminizing incisions?
Can you hear me? Yeah. So, I think this brings up a really important point around patient preparation and patient readiness. So, what we're treating is gender dysphoria and, that distress caused from it. So when you don't set, and this is true for anything in plastic surgery, it's, true for also our cosmetic population, but it's in particular true for the transgender population, to make sure that you set the expectations, what can you achieve, what can you not achieve. It's very important on the surgeon side to be really familiar with all the choices that are out there, because this patient population, more than any other, they know exactly what other surgeons are doing, what is being offered. So, they will see through it if you don't, if you don't know what you're, kind of offering and talking about. So that's one aspect. The other aspect is the mental health component. So I think, at least in my experience, I can't objectify that with data, but in my experience, patients that are, invested in their, in their well-being, and, also having a mental health professional at their side in that transition period, that doesn't mean they have to, be in mental health care, long time before, but it's quite a stressor on their life, going through these surgeries, and having a mental health professional at your side that can kind of help manage the expectations. What if the expectations haven't been met? Or also other factors, like if someone gets a breast augmentation, for example, but hasn't had facial feminization, they get a breast augmentation, now they go out in society and may even be harassed more, because now the gender expression and their phenotype doesn't quite align. So their mental health professions can really be helpful to kind of help navigate that post-operative recovery.
Thanks, Jess. We have a question related to, and an important question related to body dysmorphic disorder. I'm not sure if you can see it, but the question says, are you concerned about patients with body dysmorphic disorder which could potentially be misidentified or misinterpreted as non-binary?
Hi, that was me asking that question.
Okay, great.
Okay,
And
let me, if you don't mind, I elaborate a little bit on that. Go ahead. Sorry.
Go ahead, please.
Yeah, so hey, Bardi Amalak from Dallas. We have a program here called Genesis program, which they take kids early on from age 4 or 5 at Children's Hospital, and they treat them, they do hormone suppression therapy, and then these kids get presented to us afterwards. Now, not every child goes to the Genesis program, but I've been seeing kids in my office as young as 13, 14, 15. And, some of them I know actually personally. And just give you one example, which really distressed me, which was not in Genesis program, was a girl at age 8 or 9. She developed early with large breasts. Some form of body dysmorphic disorder, there's no question, was there, and add to that some anxiety, and then some gender issues, probably some sexual identity issues as well, bisexual and whatnot. And again, it's not my job as a plastic surgeon to extrapolate this, but you see any therapist and these kids go online and read the books and go to Google and use these terms, and then they get identified as binary with a therapist, and they present to us at age 14, 15 wanting top surgery. This is not an easy problem, of course, to figure out, are we offering top surgery to too many people? But what is your age limit for this? How do you determine at what age do you actually offer that, and when do you question these children to send them to another therapist? Go ahead. Sorry.
Jens, you want to take that?
Yes.
Sorry, I got off the line for a second.
Oh yeah, I'll finish my question. I apologize. It was a long question. But my question was how do we, at what age do we decide to operate, and especially when people have some body dysmorphic disorder and we fear that there's other issues going on?
Yeah, it's, this, so this is a topic that obviously is, something that also at times keeps me up at night, but I would say that I kind of start broadly. I've probably seen in consultation close to 1,000 patients at this point, and when I compare that to my experience with the aesthetic population or the general plastic surgery population, the kind of prevalence of body dysmorphic traits or post-operative complaints, or focusing on certain areas more than I can objectify, is really I don't feel that that's higher. If not anything, it's probably even a little bit lower than in your, kind of aesthetic population. So it's not it's really kind of an individual patient that kind of presents like that. But those patients definitely do exist, and, pose a tremendous challenge. As an example, I have a patient that has a facial feminization surgery, and, it was clear that there is both a body dysmorphic and a gender dysphoria component. So while the facial feminization can kind of help decrease the amount that the patient may be misgendered in society, it can help decrease, align her gender identity with her gender, with her phenotype. It may never treat the body dysmorphic, aspect thereof. So there is really there you need to have the mental health professional, sit down at a table with the mental health professional, ideally, if that's possible, and having this open conversation with the patient, and kind of really get to a place where just withholding the surgery for the reasons of body dysmorphia, while you could treat something else, may not be the right move either. When it comes to younger patients, same thing. I think especially for adolescents, you need to have a multidisciplinary approach. You have to have you have to have these conversations. It's not something that I would recommend you do if you're in a private practice setting, by yourself. I think there you do need to have a mental health professional that you know and trust, kind of work with those patients. But it's hard because a lot of patients are, there are not as many well-trained mental health professionals in this field that are, familiar working with younger transgender folks. So, sometimes it does, depending which geographical region you're at, patients don't have that ability. So there you kind of have to find people in your region to work with. I don't have a good answer to put your mind completely at ease, but I think it's an individual decision that at the end of the day also rests on your shoulders.
And what is the youngest age that you would offer surgery to non-binary patients?
So I would say, non-binary is just one, it's not one gender identity, right? So that's a spectrum too. And, I don't treat non-binary patients differently than I treat the trans-masculine or trans-female patient. So I essentially, treat every patient that comes through my door, the same, because otherwise you essentially devalidate, their gender identity as being non-binary identified. So the question is probably more, what's the youngest age you would offer, chest surgery? So for the trans feminine spectrum, so patients looking for chest feminization, I don't see a good reason to do this, very early on, because breast growth also in the cisgender population, happens way into, the early 20s. And, there's other means that you can, just being on exogenous estrogens does give you some breast growth. So yes, they may have a small chest that's may not be quite anthropomorphic, fitting with a cisgender chest, and may need to have surgery later in life. But I don't see a pressing issue to do that early on. When it comes to the trans-masculine population, that's a different story, because they may, have been presenting male most of their lives. In school, no one may even know that they're trans-identified, and suddenly they're having, a C cup, D cup, breast, while being, on hormones, not participating in sports, being harassed and humiliated So there you really have to, talk with the patients and the parents and kind of make a decision of when the right time is, because that's also the time where most of the psychosomatic kind of comorbidities develop. That's the age we're most vulnerable to being bullied and all these things. So just waiting for a few years may not be the right choice either.
Thanks, Jens. I think that's an important point. And I agree with Jens. I don't have a particular lower age limit. The youngest I've operated on is 14. Some of our colleagues have operated as young as 13. 16 or 17 years of age is not uncommon. I think it's highly likely that from the World Professional Association of Transgender Health, from the standard of care perspective, as we revise and update the guidelines, we will codify surgery probably at least 15 with the discretion of surgeons to go younger on case-by-case basis. And I know Phaedra is sending us a note that we're nearing the end of the half an hour. Are there any other questions from the attendees?
Okay, well, we want to be respectful of everyone's time. We want to thank everybody for tuning in tonight, and thank you, Dr. Schechter and Dr. Berli, for joining us, presenting your work, and moderating this talk. And hopefully you can join us for our next journal club, which is next month, the first Tuesday at 8 p.m. Thank you very much.